It's 2 a.m., your pager goes off. Hey doc, the patient room 404 is confused, acting differently from earlier. You've gotten this page 100 times. You know how it usually goes. But last month, that exact page, word for word, turned out to be something that almost killed a patient everyone had written off initially as just sundowning. Altered mental status at 2 a.m. is one of the most dangerous places to anchor too early, and most residents don't even realize they are doing it. Today I'm going through the 6 mistakes I still see at the framework I use every single time a confused patient page comes in. If you are a resident or a hospitalist, subscribe. I break down exactly these kinds of 2 a.m. calls every week. And it takes less than 2 seconds, and it might matter the next time your pager goes off at 2 a.m. Let's get into it. Mistake number 1, calling it delirium before seeing the patient. The page comes at 2 a.m., the patient is confused. Before you order anything here, get to the bedside, please. When I get that call, I tell the nurse, I am coming right now to assess the patient. Please get a full set of vitals and a finger stick glucose. Your first job here is not to diagnose the cause. Your first job is to determine how sick the patient is. In less than 60 seconds at bedside, please answer these questions. Is the patient awake or difficult to arouse? Are they protecting their airways? Are they following commands? Are they moving all extremities? Is the speech slurred? Is there a focal neurological deficit? Are they hypoxic? Is the blood pressure adequate? What's the glucose level? Those answers immediately determine the urgency and often point you straight to the diagnosis. A patient with a stroke, hypoglycemia, hypercapnia, sepsis, medication toxicity, or shock can all comes in as simply confused initially. So the chart will not tell you which one. The bedside often will. The rule here, never diagnose altered mental status from a page. See the patient first, please. Now, before I go through the rest of the mistakes, I want to give you the framework I use every single time. 3 words here: stabilize, localize, and treat. Stabilize first, address anything immediately life-threatening. Airway, breathing, circulation, these often happen simultaneously, not in sequence. Second, localize, and this is the question I always ask here. Is the brain the primary problem, or is the brain reacting to a problem somewhere else in the body? So brain-wise, we're talking about stroke, seizures, or post-ictal states, CNS infections, mass lesions. And for the body part, we talk about, is it respiratory failure, hypoxia or hypercapnia? Or we talk about infection or sepsis, medications or toxin effects, shock or hypoperfusion, and it doesn't have to be full-blown shock here. Or metabolic derangements, hypoglycemia, critical hyperglycemia, electrolyte disorders, uremia, hepatic encephalopathy, and withdrawals, of course. Treat the underlying cause. Remember this, altered mental status is not a diagnosis, it is a symptom. The real diagnosis is whatever is causing the brain to malfunction. Let's get into mistake number 2, missing hypercapnia. When we evaluate altered mental status or AMS, we are usually good at checking finger stick glucose and getting a full set of vitals. Sometimes the diagnosis is already right there. Let's say fever, hypoxia, hypotension, bradycardia, tachycardia. But one cause of AMS is easy to miss if you don't actively think about it, which is hypercapnia. Unlike hypoglycemia or hypoxia, hypercapnia will not show up on a finger stick or a pulse oximeter, right? You need a VBG or ABG to find it. These patients are often described as sleepy, a little confused, hard to wake up tonight. At the bedside, look for these clues: slow respiratory rate, shallow breathing, poor or decreased air movements, sometimes pinpoint pupils, and sometimes increased oxygen requirements. And remember, a normal oxygenation here does not rule out ventilatory failure. I see this constantly in patients, of course, coming with COPD exacerbation, obesity, hypoventilation syndrome, anyone on opioids or sedatives, or patients with neuromuscular weakness. Don't just look at the monitor, look at the patients. Watch the breathing pattern, listen for air movement. If the respiratory exam looks wrong, get a blood gas early. So the rule here, altered mental status plus a abnormal breathing, or whenever you suspect hypercapnia might be there, just get a BBG or ABG immediately and treat accordingly, of course. Let's go to mistake number 3, reaching for sedation too early. The patient is climbing out of bed, he's pulling at lines, she's getting combative, Pause here. Before you reach for haloperidol or lorazepam, look for common reversible causes. At the bedside, I ask, is the patient hypoxic? Is the glucose low or critically high? Is the patient retaining urine? Is the patient in pain? Is the patient constipated? Yes, constipated. Is there alcohol or sedative withdrawals? Was a new medication started today or recently? You would be surprised how often the agitation resolves after fixing one of those problems. A bladder scan showing 900 ml, an oxygen saturation in low 80s, because patient is removing oxygen, a patient is sitting in significant pain. So you just solve this problem. But if no obvious reversible causes is found, the next step is a brief reorientation attempt. This takes 30 seconds or less. I do it myself or I ask the nurse sometimes to do it. I say something like this. Hey, Mr. Smith, I'm the doctor taking care of you tonight. You are in the hospital. You are okay. It's 2 a.m. on Monday, for example. You are safe. We are all here to help you. Is there anything I can do for you? Sometimes that's all it takes. Don't underestimate it. If none of that works and sedation is necessary for safety, to allow treatment, to keep oxygen on, for example, to prevent line pulls, then I reach for antipsychotics. I avoid benzodiazepine and anticholinergic because they worsen confusion and make reassessment harder. Of course, the one exceptions, alcohol or sedative withdrawals in these, or drug withdrawals in these cases, benzodiazepines are the treatment. One final pearl here, order a one-time dose, not a PRN antipsychotic, for example. That way, if the agitation returns, you get another chance to reassess what changed. I know it sounds inconvenient, but it is the right thing to do here. So the rule here, correct reversible causes first, treat behavior only when necessary. And I did a full breakdown on delirium management and prevention in a previous video in the channel, a lot more depth than I can cover here. The link to the video is in the description field. Let's move to mistake number 4, ignoring the timeline. One of the first questions I ask when evaluating altered mental status is not, is the patient confused? But it is, when was the last time this patient was normal? The timeline often narrows the differential before you order a single test. A patient who was completely normal a minute ago and now cannot follow commands is a very different solution, or very different situation from a patient who is been mildly confused for the past 3 hospital days, or demented to start with, right? Sudden changes, think stroke, seizures, acute medication effects, hypoglycemia, critical hyperglycemia, and some infections present suddenly. Gradual changes, things of delirium, some infections, metabolic derangements like electrolyte disturbances, medication accumulation. The patient's nurse can quickly provide you with the timeline in most cases. We can also get it from the sign out or from the sitter who's at bedside, so don't skip that question, please. So before you build a differential, establish when the mental status changed. Let's get into mistake number 5, letting the workup drive the diagnosis. Altered mental status can trigger diagnostic panic. The reflex becomes CT head, full blood panel including ammonia, ABG, MRI sometimes, EEG even, neurology consult. Slow down here. By this point, you should already have a working diagnosis based on your bedside evaluation, timeline, vitals, and exam. The workup confirms your leading diagnosis or exclude dangerous alternatives. It is not a fishing expedition here. Not every altered patient needs a head CT at 2 a.m. and not every confused patient needs a full infectious workup. Here is how I frame it. By the time I order a head CT, I already think this is something intracranial going on, like a stroke or any other processes. I'm not ordering it to go looking. Order the test that answers the questions you are actually asking. So the rule here, the workup follows the diagnosis, not the other way around. Let's get into mistake number 6, waiting for the workup before treating the obvious. Residents sometimes freeze, waiting for the head CT, the blood gas, the neurology maybe evaluation, the lab results. But many altered patients declare themselves before any of that comes back. If the glucose is 38, give dextrose, right? It's very obvious. Now, if the patient is severely hypoxic, fix the oxygenation before doing any tests. If the patient is septic and hypotensive, start resuscitation. If the patient has opioid-induced hypoventilation or even suspected, give naloxone. You can continue the workup while treating the physiology. In fact, that's usually exactly what you should be doing. The goal is not to make the perfect diagnosis first. The goal is to stabilize the patient while you figure out the diagnosis. Remember the stabilize, localize, and treat. The rule here, treat obvious, immediately reversible causes while the evaluation continues. And one more thing here, escalation. Altered mental status patients can be difficult to triage. Floor versus step down versus ICU. And here is the thing, the vitals can initially look completely normal. The question is not, is the patient altered or not? The question is, why is the patient altered and where is this going? Watch the trajectory. A patient becoming progressively somnolent should worry you far more than a patient who is just simply confused. Patients often need higher acuity when mental status is worsening, airway protection issue, or airway protection becomes questionable, or hypercapnia that's progressing on serial gases despite BiPAP, for example, severe agitation that not responding to initial treatment and is heading toward needing a drip, or frequent reassessment is required, like frequent neuro checks. The underlying physiology is unstable. And remember this, agitation gets attention, CO2 narcosis quietly arrests. So remember that. So if your gut tells you the patient is heading in the wrong direction, call early. That's not overreacting, that's a good medicine. So escalation depends on trajectory, airway risk, and underlying physiology, not just the mental status label. So to conclude here, when the pager goes off at 2 a.m. for altered mental status, don't anchor on delirium. Go to the bedside, check the airways, look at the breathing pattern, review medications, check glucose. Of course, every time somebody altered, I check glucose. Even if they're not diabetic, look for the physiology that explains why is the patient become altered tonight, because overnight medicine is really about memorizing a differential. It is about recognizing who is quietly getting sicker before the monitor catches up. And many of the most dangerous causes of altered mental status are completely reversible if you identify them, of course, early enough. In the end, if you'd like to receive a written summary or access the clinical algorithm that goes with this video, the one page that you quickly can refer to at 2 a.m., it is available on my Substack and newsletter for subscribers. The link to join my Substack is provided in the description field. And again, remember to subscribe if you have not done so. And if you feel this video was useful, please give it a like. Thanks for watching, and I'll see you next video.